Disaster preparedness in healthcare means being ready for the unimaginable. Hospitals don't get to choose when a hurricane hits, when a mass shooting happens, or when a virus spreads across the world. But what they can control is how prepared they are when it does. Every healthcare facility is required by the Joint Commission to have a formal emergency preparedness plan, and every staff member must practice that plan at least twice a year. These plans aren't just paperwork, they're life-saving roadmaps. Usually, they're developed by the hospital's Safety or Disaster Management Committee and supervised by an administrative liaison. Before the emergency plan is written, the committee performs a hazard vulnerability analysis. They study the community to predict what disasters are most likely to occur. A hospital near a chemical plant prepares differently than one near the coastline. The team talks with local law enforcement, fire departments, and EMS to identify patterns, train derailments, traffic density, flood zones, even earthquake risks. Any area where large groups gather, schools, stadiums, courthouses, is also flagged as high risk. Once these risks are clear, the committee evaluates the hospital's resources. The goal is self-sufficiency. Every facility should be able to operate independently for at least 96 hours, ideally a full week, without external help. That means enough food, water, medication, power, and staff coverage to keep patients safe if outside supply chains collapse. The plan also has to outline how patients will be prioritized if resources run short. For instance, how will ventilators be assigned if there aren't enough? How will care teams be reorganized if half the staff can't make it in? Preparedness means thinking through the worst-case scenarios before they happen. When COVID-19 emerged, hospitals faced exactly that kind of test. The idea of social distancing became common language, meant to slow infection and keep hospitals from being overwhelmed. But in places like New York City and New Orleans, the surge still came. Critical supplies ran out. Ventilators, respirators, face shields, even sanitizer. Healthcare workers begged for more protection, and many paid the ultimate price for serving without it. In February 2020, the Secretary of Health and Human Services issued an emergency use authorization so that more types of respirators could be used. The FDA worked around the clock to expand manufacturing. By April, FEMA created the COVID-19 Supply Chain Task Force, built around 4 steps: preservation, acceleration, expansion, and allocation. Those efforts, combined with the Defense Production Act, pushed private companies to make what hospitals desperately needed. It was a national reminder that preparation must include supply resilience, not just protocols. A hospital's Emergency Operations Plan, or EOP, is its playbook when disaster hits. The plan must integrate local, state, and federal coordination, and it needs to work seamlessly with community agencies and volunteers. But it also has to stay flexible. No two crises are the same. The EOP covers several key components. It starts with an activation response: who makes the call, how it's triggered, and where operations shift. It includes an internal and external communication plan, because the ability to talk with EMS, fire, and local command centers determines whether chaos or coordination wins. There's a coordinated patient care plan that defines how patients move in and out of the facility and how transfers are handled. Security plans are also critical. During a disaster, control of people and space can make the difference between order and panic. The plan identifies external resources, who to call for supplies, transport, or backup power, and defines exactly how to activate those resources. It includes strategies for people management, traffic flow, and handling the media. It outlines data management and backup systems in case electronic records go down. There's a demobilization response, because knowing how to stand down is just as important as knowing how to ramp up. Afterward, there's a corrective plan or after-action report to review what worked and what didn't. Hospitals are required to run regular disaster drills, ideally full-scale community exercises that test every link in the chain. Realistic drills expose weak spots before real lives depend on them. When a disaster occurs, notification usually comes from outside sources like EMS or local command. If communication lines are intact, hospitals will get a rough estimate of incoming patients, but they rarely know how many will self-refer and walk through the door. The plan has to be crystal clear about who activates it and how. During the COVID-19 pandemic, the CDC issued specific guidance for maintaining hospital operations, staff safety, and infection control. The goal was to prevent spread inside the facility and ensure that every worker had the training and equipment to handle the crisis safely. One of the most important elements in any mass casualty response is patient identification and tracking. Disaster tags are used for this, numbered cards that travel with each patient. They list triage priority, name, age, injuries, and treatments provided. Those tag numbers are logged so command centers can track patients, assign beds, and communicate with families. Triage itself changes dramatically in a disaster. Under normal conditions, the sickest get the most resources. But in a mass casualty event, the guiding principle shifts to the greatest good for the greatest number. Resources go to those most likely to survive with intervention. It's harsh, but necessary. A patient in cardiac arrest from massive trauma may receive only comfort care if survival is unlikely, while limited supplies are directed to those with treatable injuries. Triage officers quickly assess and tag patients at the scene. Then EMS provides life-saving measures and transports them. Field triage is only the first step. Secondary triage continues inside the hospital as conditions evolve. Triage categories are color-coded to make priorities clear. Red means immediate, life-threatening but survivable with quick treatment, like a tension pneumothorax or major burn. Yellow means delayed, serious but stable enough to wait, such as soft tissue injuries or fractures needing fixation. Green means minimal, minor wounds or fractures that can safely wait hours or even days. Black means expectant, injuries so severe that survival is unlikely. Those patients still deserve comfort, privacy, and dignity. At the hospital door, an experienced emergency provider should direct triage. Traffic control is just as critical as medical judgment. The triage area might be outside the entrance to prevent congestion and to allow reassessment as patients arrive. Many hospitals use the SALT triage system: sort, assess, apply life-saving interventions, and determine treatment or transport priorities. It works for any age and any event type. The faster the sort, the sooner resources go where they matter most. Inside the hospital, internal preparedness becomes its own challenge. Every facility must maintain a survival kit, often modeled after American Red Cross guidelines, but customized for the hospital's unique needs. The emergency committee should identify the 10 most critical daily medications and predict what extras might be needed, like antidotes for chemical exposure or antibiotics for biological threats. The process for requesting, receiving, and restocking supplies must be known by everyone involved. Communication during a disaster is everything. It's not just about radios and phones. It's about message control. The hospital's plan should define how to communicate with the media and the public. Only a designated spokesperson, usually the public information officer, should release statements. Media access to patient areas is never allowed. Updates should focus on verified facts. What is being done, not speculation or casualty numbers. At the same time, the media can be allies in spreading instructions about shelter locations, quarantine zones, or public health alerts. Families also need structured communication. They deserve honesty and updates, but they shouldn't be allowed in triage or treatment zones. Hospitals should designate safe areas staffed by counselors, clergy, and social workers. During outbreaks like COVID-19, visitor restrictions can make this harder. Video calls, messaging platforms, and remote support became lifelines for families separated from loved ones. Hospitals must ensure that technology access isn't limited only to those who can afford it. Equity in communication matters just as much as infection control. Nurses make up the largest portion of the global health workforce, and their role in disaster response is unmatched. In extreme situations, nurses may need to perform tasks beyond their usual scope: intubating, suturing, inserting chest tubes, or leading triage. The key is maintaining patient safety, understanding state regulations, and relying on training. Cultural considerations also matter. Disasters don't affect just one kind of person. Patients and providers come from diverse religious and ethnic backgrounds. Nurses must respect differences in family structure, privacy, rituals for the dead, dietary rules, and religious practices. Some communities even have their own emergency plans that hospitals can integrate. Leadership during crisis requires clear delegation. nurses may find themselves assigning duties to students, volunteers, or staff from other departments. That means quickly assessing who can do what and matching skills to needs. Even when resources are limited, patient safety and proper delegation remain non-negotiable. Ethically, nurses often face impossible choices during disasters, balancing care for the community with compassion for individuals. Traditional principles like autonomy, beneficence, and justice still apply, but they take on new weight when resources run out. The goal becomes fairness and survival, not perfection. COVID-19 magnified these ethical pressures. Nurses cared for dying patients who couldn't see family, worked without adequate PPE, and sometimes had to ration life-saving care. Moral distress became part of the job. The ANA reminded nurses that self-care and family protection are also ethical duties. A nurse can choose not to respond to a call for duty if safety cannot be ensured or family needs cannot be met. That decision deserves respect, not judgment. Disasters also take a psychological toll. People exposed to trauma may develop anxiety, depression, PTSD, or substance use problems. Healthcare workers are especially at risk for compassion fatigue and burnout. The longer and more dangerous the exposure, the higher the emotional cost. Nurses can help by listening, offering reassurance, and connecting patients and coworkers with counseling resources. Encouraging normal routines and limiting media exposure can also help victims regain control. For staff themselves, hospitals rely on critical incident stress management, CISM, teams. These teams provide education, rest cycles, and post-event debriefings for responders. There are hundreds of CSM teams across the country, including in the military and major industries. Their goal is to prevent long-term psychological harm by offering structured support and follow-up after the crisis ends. At its core, disaster preparedness is about readiness, adaptability, and humanity. It's not only about logistics or checklists. It's about staying steady in the storm, keeping communication clear, ethics intact, and compassion alive. When the unthinkable happens, nurses are the calm in the chaos. They bridge fear and hope, bringing order when the world tilts off balance. And that, more than any piece of equipment or protocol, is what saves lives.